underway. And welcome to the first of many International HHT Challenging Case Series. And today we'll be focusing on pulmonary AVMs. And I would like to thank our host organization, the HHT Center at New York Presbyterian and Columbia University Irving Medical Center. So thank you guys very much. Before we get started, I'm going to go over a couple of topics. Let me just pop into that. So the format of today's meeting will be presentation and discussion for each case. We will have 5 cases and they will be limited to about 15 minutes. Please stay muted during the presentation. We want to respect our presenters. They've put together a really great show for us today. Feel free to use the chat at any time during the presentation or discussion. We encourage any sort of discussion in the chat. And during the discussion portion after the presentation, there's no raising of hands. We just ask that you please be respectful of other attendees and stay muted when somebody else is talking, and then unmute yourself to talk. And a quick announcement, our next meeting will focus on liver AVMs and will take place on a weekday evening in October. Details to come in the next 2 weeks. And now I'd like to introduce Miles Conrad, an interventional radiologist and co-director of the HHT Center at UCSF. Miles, you can take the show.
Hello, thank you for joining us today. In response to requests from our medical and scientific community for more discussion and collaboration, Cure HHT is excited to launch the International HHT Challenging Case Series. This series of meetings will occur every 2 months approximately, with rotating hosts from various centers of excellence, and will serve as a platform for the medical community to present and discuss complex HHT patients in an interactive format to gain insight from both clinicians and basic scientists, so that we can hear from all of you as you are the experts in the global community. The overarching goal here today is to foster discussion, share knowledge, spark innovation, and improve patient care. This first meeting is hosted by Columbia University Irving Medical Center HHT Center of Excellence, which is the only center in New York designated as a Center of Excellence by Cure HHT and was founded in 2016. Our center directors today are Dr. Keith Brenner and Vladimir Shenzon. After graduating from Johns Hopkins, Dr. Brenner completed his postgraduate training at Columbia and fellowship in postgraduate training in internal medicine and fellowship in pulmonary and critical care medicine, and is an assistant professor of medicine. Dr. Brenner has been the center director since 2020. Dr. Vladimir Shenzon is an assistant professor of radiology in vascular and interventional radiology section at Columbia and is the associate director of the Columbia HHT Center. He received his medical degree from Mount Sinai School of Medicine and completed a residency in diagnostic radiology at the University of Medicine and Dentistry at New Jersey and the New Jersey Medical School. He completed his fellowship in vascular and interventional radiology at Mount Sinai in New York City. And without further ado, I'd like to welcome Dr. Shenzon and Dr. Brenner.
Hi, good afternoon, everyone. And thank you again for having us to the Cure HHT community and for allowing us to host this first virtual event in the Challenging Case Series focused on pulmonary AVMs. Myself and Dr. Shenzon are really pleased to do this. And without further ado, I'm going to turn you over to Dr. Suraj Patel, who's, and Suraj, you can start taking over the screen if you'd like. Suraj is a IR interventional radiology fellow here at Columbia. He did his training at SUNY Downstate in radiology, where he was chief resident, and has had a lot of interests in research and writing, and has now gained an interest in HHT since joining our team. So Suraj, why don't you go ahead?
Okay. Thank you all for having me. I appreciate it. It's an honor to be able to present this case. Thank you, Dr. Shenzon. Thank you, Dr. Brenner, for the opportunity. So without further ado, let's get started. here is our first case. This is a 50-year-old, it's a case of extensive pulmonary AVMs and central HHT. This is a 50-year-old female diagnosed with HHT with workup in 2017 for septic shoulder and found to have incidental pulmonary nodules, which proved to be pulmonary AVMs with an additional long history of epistaxis as well as lip and nail telangiectasia. She's been chronically hypoxic since her since her diagnosis with an SpO2 of roughly 83 to 87% in 2018 when she was seen by our pulmonology team. Colonoscopy proved negative in 2016 and an EGD at the same time demonstrating multiple bleeding angiectasias within the duodenum. No, she doesn't have a history of liver AVMs, and her TTE in 2018 proved relatively unremarkable, as you can see here. She did have a brain MRI in 2018, which was unremarkable at the time, and she developed a subsequent brain abscess in an outside hospital, which she underwent surgical resection for. Here we go on. So here's the case. Here's the chest CT from 2018 demonstrating at least 9 on the right pulmonary AVMs and about 4 on the left, the largest between 1 to 2 centimeters or so. Now, this is not necessarily the best representative example, but you can see couple pulmonary AVMs here as well within the right upper and right middle lobes extending to the lower lobes, as well as a couple large ones within the left lower lobe and additional ones within the left lower lobe. So we began treatment in 2018. We staged the treatment with serial embolizations. Now the goal was to treat completely, but staged to reduce risks of cor pulmonale as well as to allow cardiac recompensation. Now our initial pulmonary arterial pressure was 14 at that time, and that her transthoracic echo showed a peak of 25, which is just fine. So as you can see, we started to treat in 2018, 3 treated in the left. I can just go on, but I'll spare you the details here. As you can see, we've been treating about 1 to 5 every treatment and intermittently over a span of a couple months. Over a span of a couple of years in between, with a couple months in between. So here's a couple representative pictures of a few angiograms. Didn't want to show every one of them because that would be a little too extensive, but just showing you a couple pictures of how extensive our embolizations had been and can further be, and you'll see in the left lower lobe here, multiple large pulmonary AVMs of which have been treated with multiple coils, as well as starting to begin treatment of smaller ones within the right lower lobe. And as you can see, there are a few left untreated here, 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 as well as here within the right lower lobe, and a few others. So seen again by a pulmonologist in March of this year and noted to have an increase in SpO2, which is remarkable considering the treatments, and a repeat CTA just to evaluate what was residual, demonstrated a few residual untreated but stable pulmonary AVMs. As you can see, largest within the right upper lobe, about 1.3 to 1.1 centimeter, and additional ones that are a little bit smaller, sub-centimeter, throughout the left and right lower lobes, or left upper and right lower, as well as lingula, and even smaller ones, about 8 total. So a couple CT images, coronal, that you can see here, this one that we saw prior, stable in size, an additional one, and a couple other ones that we have yet treated. So in this year, she would begin further treatment. 3 right-sided pulmonary AVMs were taken care of, as well as 6 right-sided pulmonary AVMs treated again, with 1 final pulmonary AVM remaining planned for treatment. Also, she's pending a TTE. So, and here's another post-treatment image from our angiograms demonstrating significant coil embolization throughout. Now you can see here, there are a couple pulmonary AVMs that were left, of which had subsequently been treated, and with one left to go. So what was learned and future insights. Now, serial treatments have prevented cor pulmonale in our patient population, and that's something that we've recognized thoroughly, that serial treatments can be beneficial with patients with extensive pulmonary AVMs. A patient with extensive pulmonary AVMs after embolization does not necessarily develop pulmonary arterial hypertension. And that being said, it's important to know that she didn't have liver AVMs, which would give her a reason to have pulmonary arterial hypertension. In this case, she has a very low resistance system. So one would expect possibly, but not in this case. Now, balloon occlusion techniques may not estimate the effective pressure changes over time after embolization. That's something that we're beginning to start to realize and study. And pulmonary arterial pressure should be acquired on each serial embolization as standard of care, and to understand the physiologic changes over time. Now, the questions that we had raised were something that we've been thinking about for quite a bit, as well as trying to understand the true physiology. Now, as pulmonary AVM embolization can mimic a chronic PE, should we expect pulmonary arterial pressures to rise over time, keeping in mind the low resistance system? Additionally, another question, if so, with routine pulmonary arterial pressures obtained, should we stop treatment when levels surpass 25 and I mean to say mean, that is, milligrams per mercury? Now, have increased pressures after treatment of pulmonary AVMs resolved at next or subsequent stage treatments? Meaning, does the pulmonary vascular bed recruit reserve? And is it appropriate to use balloon occlusion techniques to evaluate changes in pulmonary arterial pressure prior to embolization of large pulmonary AVMs? Is it a good predictor of eventual PAVM? Going on. And a quick literature review, which I'm not sure if I'll have time for, but here's an article from 2008 and 2009, of which the 2009 one was reviewed by the same author. And the suggestions were that embolization of pulmonary AVMs did not lead to a consistent increase in resting pulmonary arterial pressure in a series which excluded individuals with severe pulmonary arterial pressure or hypertension. And it suggested that for most patients with a pre-existing severe pulmonary arterial hypertension, the risks of pulmonary AVM embolization outweigh the potential benefits. Now, balloon occlusion techniques did not predict a significant rise in mean pulmonary arterial pressures following definitive embolization, as well as the presence of, well, I can just go on here. Let's go on to the next literature review really quick before we start a discussion. This study just briefly demonstrated that HHT patients undergoing pulmonary AVM embolization had a significant prevalence of pulmonary hypertension, and the presence of pulmonary hypertension is associated with significantly higher mortality. And the study underestimated the prevalence of pulmonary hypertension in the HHT population, as only patients with HHT were undergoing selective pulmonary angiograms for embolization in this study. So thank you for letting me present. I appreciate it.
Great, Suraj. That was great. I don't know if we're just going to throw it out to the group. I know this is a common scenario where there's multiple lesions to be treated, and we're worried about the patient's future pulmonary vascular reserve, and maybe someone can comment on how they sort of approach the situation.
Hi, Suraj and Keith. It's Marie phoning. Thanks for presenting this case and these really good questions. So, first of all, I'd say that our experience over 20 years of embolizing patients with pulmonary AVMs, and in our experience, I would say that, probably at least a third of the patients have multiple AVMs, maybe not quite as diffuse as this patient, but have, bilateral multiple pulmonary AVMs with a significant burden of disease. And we've had no cases of pulmonary hypertension developing post-embolization. I would say that the situations where we've been careful and have staged our embolizations have been when someone starts out with pulmonary hypertension. And so we've been certainly concerned in those patients about whether we might cause pulmonary hypertension, but I have not to date ever seen a patient develop pulmonary hypertension post-embolization. I'd be curious to hear what the others say as well. But I think that the pulmonary vascular bed is either normal enough or in fact shunting enough that it's able to accommodate the redistribution of flow. That's my impression.
Okay. Mark Chestnut out here in the Wild West. I would agree with that. I'm more concerned. I'm more seeing complications of brain abscesses and residual ones that weren't fixed. So I'd be more worried about the morbidity and mortality of those than the impact. And while it's different and everything, the analogy I often do is the physiological hemodynamic effects of pneumonectomies that my surgeons do all the time on the pulmonary vascular bed in the right heart. Again, assuming the patient's going in have low pulmonary resistance and no pulmonary hypertension to begin with. But in those who start out pretty normal, I think the others in the call and stuff have been, we've gotten away with it, and I've kind of done it blindly. But a lady like this who's profoundly persistent hypoxemic, I think it's the hypoxemia plus the persistent interpulmonary shunts of this kind of size that I'm really worried about brain abscesses and strokes.
Yeah, this Jim Gossage, I agree with Marie and Mark there. And I put together a couple of posters over the years for the HHT conferences. And we found that when we did some before and after right heart caths, right, during the embolization procedure. So I'd slip the heart cath in. When the patients had some big AVMs, we would measure the pressures, cardiac output. Our guy would embolize them. And then I would slide the catheter back in and remeasure. And basically, the cardiac output is going down by the amount that we are reducing pulmonary vascular or increasing pulmonary vascular resistance. So it almost looks like you just have excess blood flow is going through these AVMs, almost like a shunt sink, a flow sink. And you shut the flow off, and the heart doesn't need it, the body doesn't need it. So cardiac output goes down, PVR goes up slightly, but it doesn't become abnormal, and then PA pressure stays unchanged. So, and especially if the patient doesn't have, if the amount of shunt is less than 20%, then the effect of shutting off that flow is going to have a minimal impact on total PVR. And unless they're really compromised to begin with underlying pulmonary hypertension, increasing pulmonary vascular resistance by that much has very little impact on pulmonary artery pressure. So I agree. I think it's very uncommon if PA pressure is normal to begin with.
It's Scott Traratola from University of Pennsylvania. I agree with all of you. I just want to add that, as you know, we've been very strong proponents of treating as many PAVMs as possible, as quickly as possible. And I think I would have made an effort to get this person treated, within a couple of months.
This is Jeff Pollack. So I agree with most, and I also was going to make a comment that Jim made that that pulmonary hypertension, I think, development remembers flow times resistance, and so you are decreasing flow. And I don't think these quite mimic. These are not quite the same as chronic PE, because you have abnormal flow that you're reducing as well. In our experience here, I'd say that I very, very rarely, I won't say never, seen pulmonary hypertension develop. I've never seen clinically symptomatic pulmonary hypertension develop. I will say that. And I think it's generally when Bob was pushing the envelope, trying to treat a lot of diffuse, extensive embolization for extensive diffuse disease. Outside of that, I wouldn't say I've seen it. Also, I've definitely treated patients with pulmonary hypertension. And what I do is then I'm constantly measuring the pressure as I go along and embolizing if there's multiple feeders to one lesion or several lesions, I'll just be in the middle of the procedure, I'm constantly measuring the pressure. And I really have not seen an intra-procedural rise, except I can vaguely remember in one patient. And that's the kind of thing that can even vary in a patient doing nothing from moment to moment. I would caution though, in our experience with diffuse, my big concern is when you start chasing after, and this is not diffuse what you showed, this is multiple extensive sizable ones, right? Where you're worried about, you can have larger stuff go through. My big concern when you go through multiple sites of embolization for extensive tiny ones is the years down the line systemic reperfusion and apoptosis. That's the one thing that I do worry about when I start embolizing a lot.
Great, thanks so much. And that was a great case and great discussion. We're going to be on to the second case, which is coming to us from UCSF. We have Dr. Jinwan Yum, who is an IR fellow, and Rebecca Abelman, who's a fellow in infectious disease. And they're going to talk about an approach to a patient with a suspected mycotic pulmonary artery aneurysm. So Dr. Yuma, you should be able to take over the screen.
Okay. Are you able to see the screen?
Yes.
Okay, terrific. Well, thank you very much for the introduction. I'm joined here today by Dr. Rebecca Abelman, who is a second-year infectious disease fellow here at UCSF as well. And also our mentors, Dr. Miles Conrad, who you all met, as well as Dr. Annie Lukemeyer, who is professor of medicine and infectious disease here at UCSF as well. So we are very excited to present our case today and discuss the infectious complications of HHT. And during our presentation, we hope to identify the common infectious complications for patients with HHT, define mechanisms for infection in pulmonary AVMs, and discuss management for HHT patients who present with infection. So to our case, this is a 71-year-old woman with no known past medical history who presented with new horizontal diplopia and ptosis, found to have a large 3.1 centimeter right cavernous ICA aneurysm. She was discharged on medications with plan for neuro IR intervention following elective angiogram. However, 10 days later, she returned with melena and epigastric abdominal pain. And so several tests were performed, including CT abdomen pelvis, which demonstrated multiple hypodensities in the liver and spleen, concerning for infections. And surprisingly, her blood cultures actually came back positive for actinomyces species. She also had an EGD performed, which demonstrated multiple non-bleeding angiotasias. And so given clinical concern for HHT, interventional radiology was consulted for discussion for embolization. And so CT chest, CTA of the chest was performed, as well as MRI of the abdomen to better characterize these hepatic lesions. And so here are, here's a CTA demonstrating multiple large pulmonary AVMs as indicated by the arrows there. And then here is MRI of the abdomen, which demonstrates these multiloculated enhancing lesions in the liver, as well as the spleen. And in addition, she was also found to have extensive portal vein thrombosis, as you see here, as well as thrombosis of the splenic vein, which you see here, and some in the confluence as well. And to top it off, she was also found to have these presumed mycotic pseudoaneurysms involving the hepatic arteries, as well as the left renal artery. And of note, this patient was not found to have liver AVMs. And this is just a coronal representation of the multiloculated abscesses in the liver and spleen. So now I will pass over the mic to Rebecca.
And I'm just going to take a couple minutes to talk about actinomyces and some of the infectious complications that we see with HHT, and then open it up for discussion. So actinomyces is an organism that we see relatively commonly in infectious disease consultation. It's an indolent gram-positive anaerobic bacteria, but the context we typically see it in is in actually oral infections. So that's the most common form of actinomyces. And in terms of abdominal infections, it's something that we see relatively uncommonly. It's seen mostly in the abdomen in the context of intra-abdominal surgery, or we see it with intrauterine devices. It can cause hepatic abscesses, although liver abscesses are overall an uncommon manifestation of this bacteria. And then in doing a review of the literature, it looks like there have been about 10 cases reported of disseminated actinomycosis in HHT patients. And as actinomyces is often in the mouth with a lot of other bacteria, unsurprisingly, about half of these cases were polymicrobial. Next slide, please. So when looking at potential infectious complications of HHT, the main study that I saw that looked at a large cohort of patients was out of France. It was a retrospective study. And they did a catalog of the various infections that were seen in patients with HHT. So surprisingly, 67% of patients had extracerebral infection if they presented with infection, and those included things like cellulitis, which we see very commonly, and the most common organism was Staph aureus. There was a report of cerebral infection, and those were typically polymicrobial, and then those were also heavily associated with pulmonary AVMs, and that represented about 33% of those patients. And then in this study, and was seen in some other studies, they looked at risk of cerebral abscess, and it was at over 100x for patients with HHT, and there was a much higher rate with patients within HHT subsets who had pulmonary AVMs, so it was about 400 times higher. The mechanism is thought to be from shunting, from pulmonary to systemic circulation via the pulmonary AVM, and other studies separate from this clinical infectious diseases study has found that overall the most common bacteria is actually strep, although we do see a lot of staph infections as well. In terms of the hepatic abscesses, so overall they were uncommon in this cohort, and there are other case reports of patients with HHT with hepatic abscesses. In this particular study, it was 7.4%, representing 5 patients. And then actinomyces infections were seen in patients with cerebral abscesses in this cohort, and that was in 2 cases. Next slide, please. So in follow-up, she preferred discharge with outpatient follow-up rather than getting IV antibiotic therapy, which is typically what we would recommend. She was discharged on both amoxicillin augmentin and amoxicillin, high-dose amoxicillin, and she was kept on that for several weeks. She had an interval CT abdomen pelvis that showed improvement in the hypodensities in the liver and spleen, as well as decreased burden of the thrombus, both in the portal and splenic vein. And as you can see on the right here, this is an image from the embolization that was done by Dr. Conrad, and 5 pulmonary AVMs were embolized earlier this month. And she's been consented for genetic testing, but that hasn't been performed yet. Next slide, please. So just a few summary points. So in summary, HHT patients, there is an increased risk of infection, particularly cerebral abscess in the context of a pulmonary AVM. Common organisms include both staph and strep, although actinomyces has been associated with HHT. And hepatic vascular malformations can occur with HHT, but liver abscesses are a rare infectious complication, particularly in the setting of someone who does not have hepatic abscess. Hepatic AVMs. So we had a couple questions for discussion, but we're open to hearing other thoughts if people have other thoughts on this case. But I think our overall question is, are these aneurysms mycotic? And the interesting component of these aneurysms is that they are in a branch location, which is unusual. What is the risk, or how do you think about risk of embolization in the setting of ongoing active infection? And then, is HHT an immunocompromising condition? I know that some studies have been implicated in showing that there's, at least with certain genetic mutations, changing the killing capacity of neutrophils and monocytes, and just thinking about how to conceptualize that from a patient perspective.
Hey, so great job, both of you. That was a wonderful presentation. I want to just throw it out to the group now, if anyone wants to take a stab at those main 3 points. But perhaps, Rebecca, you can go back to that questions for discussion there and see if anyone in the group has wants to tackle one of these questions.
Hey, Rebecca, Jim Gossage, I've got a question for you. You pointed out that 7.4% of the patients had hepatic abscesses. Were those mostly in patients with lung AVMs? Do you know? Yeah,
so unfortunately in this paper, because I think it was from an infectious disease perspective, they didn't stratify based on the type of AVMs that patients had, although overall they did look at risk of infection with patients with various types of vascular malformations. Pulmonary AVMs did have an increased risk of infection, as did hepatic AVMs. But unfortunately, they didn't stratify by either genetic mutation or by type of AVM.
And this may be a question for Dr. Yoon, but you mentioned no liver AVMs. But when you were sliding through the scans of the abdomen, I was very impressed with the size of the hepatic artery. And I thought to myself, this patient's got liver AVMs. So was just curious as to whether that's really true that they don't have liver AVMs, or was this some kind of funny imaging, or maybe I misinterpreted it.
Yeah.
Or maybe liver abscesses cause increased hepatic blood flow.
Yeah, so I think there were a couple of things happening that unfortunately we had to kind of gloss over for the sake of time, but partly why the MRI was performed was because we weren't certain. We had the same thought, could these all be AVMs based on how it appeared radiographically? I think based on the results of the MRI, and Jawan can comment on this more than I can, but based on the appearance on MRI, they seemed a lot more consistent with hepatic abscesses. And then the other thing that was interesting about this case is the thrombosis, the portal vein thrombosis. In the infectious disease world, we do see that with hepatic abscesses. It's called pyelophlebitis, which is an infected clot in the portal vein. So I'm wondering if that's also what you're seeing on the imaging.
I can confirm there was no liver AVM. And, my main interest with this case is we see brain abscess as a result of PAVMs from time to time, obviously. But I've just never seen widespread infections in in the spleen, in the liver, as a result of pulmonary AVMs. And in addition, what we think are mycotic pseudoaneurysms in 2 in the left kidney and 1 in the right hepatic artery. And then the one in the brain, which we're not showing you here, but the one in the brain is really at the base of the internal carotid artery at the skull base. And that's not in a normal place for a mycotic pseudoaneurysm to form after an embolic infected clot. That's usually, a brain abscess is usually what you get. So I guess our question, there it is right there. So our main question is, have you seen many widespread infections from PAVMs, especially in the setting of poor dentition?
Miles, and on all of you presenting, this is a really interesting case and really difficult questions you're asking. I can answer the easy ones. First, I haven't seen this before. I haven't seen widespread infection in patients with pulmonary AVMs. I have seen liver abscesses in patients with liver vascular malformations, even if they don't have AVMs, but if they have, diffuse small malformations and shunting, but they don't usually look like this, I think. I'm no expert at looking at the imaging, but usually it's, peribiliary abscesses that we're seeing, and this looks much more distal. So this looks like a different phenomenon than I've seen even recently in a few patients with liver abscesses. So, and I think that the hardest question of all is there does HHT affect the immune system? Is there any, immunodeficiency? I think we do know that there are some abnormalities that have been described, but we have not clearly connected those with specific infection risks, to my knowledge. I think that there's a lot more to be done in this way, though. And I'm hoping actually with one of the things with the registry, we're trying to really gain more information about severe infections in HHT and what might be the determinants of those. But I think that it may be a more complex question, even the brain abscess question, than just having lung AVMs or not. Maybe there is something to, maybe there is an immune component as well.
Great, thanks so much for that. There's obviously a lot more discussion that we could have on this in this case, but we are going to move on to the next case just at a time. So our third case is from the University of Colorado School of Medicine. This is Dr. Rashan. He's the co-director of the HHT Center and a vascular and interventional radiologist who's going to be discussing a challenging case of pulmonary AVM recanalization.
Thank you, Dr. Brenner, and hosts and all of your co-hosts for the Columbia University, the Cure HHT community, Dr. Miles Conrad, and all of our colleagues. Short presentation of a 67-year-old female with a history of HHT presenting for her routine follow-up. She was shown to have right lower lobe and left upper lobe pulmonary AVMs treated 1 year ago at an outside institution, and on repeat CT imaging, it demonstrated persistent flow in the previously treated pulmonary AVMs. Her oxygen saturation on room air that time was 92%. Won't show you the CT scan. We'll go directly to the angiography. And before I actually proceed, just a verbalized disclosure of an off-label use of ethylene vinyl copolymer, or onyx. So this is a video showing the persistent flow through the coil pack of an AVM. And this is just a nudging of the catheter at the origin of the previously embolized AVM. Now, before I proceed, whenever I approach these particular dilemmas, I try to get a wire and catheter through them first in hopes of getting it as distal as possible and nesting other smaller coils within the coil pack. However, as some of you may know, that we're dealing with a brick wall with all the fibrin and fibrinous material within these coil packs as well. So things that we want to think about are how far can you actually coil back or embolize proximally to this coil pack versus trying to get as distal as possible to try to treat the reason why we have a recanalized pulmonary AVM. And moving on, nudge the microcatheter in here, and what we can see on screen left, the opacity around and within the previously embolized AVM, that's the onyx that was percolated into the cavity itself. And again, trying not to get any non-target embolization or any onyx in the branch vessels to that AVM. And on repeat or post-embolization angio, we see that there's no more flow through this AVM. Now, this actually worked out really well on this side. Now, we brought the patient back for another AVM that was recanalized in the left upper lobe. These images is a CT image showing the recanalized AVM itself, again showing that there is embolization or actually recanalization. Now, moving forth, we see that there was onyx that was actually opacified or embolized in a non-target vessel, normal branch, which sometimes whenever we're embolizing with coils, we can embolize, or that's a risk factor for these procedures. However, whenever I see this is whenever I want to stop. It's something that I don't want to see at all, as well as any proximal non-target embolization that can be seen in these patients. And as we're dealing with a liquid embolic, there is that risk of going through and through the shunting and embolizing across the heart and into the brain itself. So those are some things to consider. This is nothing that we do first and foremost, but whenever we cannot get a catheter across and to coil within these recanalized AVMs. Now, this patient had an increase in O2 of 94%, and there was no significant consequence from the non-target embolization, however, was concerned about that. Some questions that learned and discussions for the rest of the audience. What was learned? Well, it's feasible to use ethylene vinyl copolymer for recanalized pulmonary AVMs. However, I noted that this is an off-label use. It's typically used in the neurointerventional world for aneurysms, also looking for other indications, but nothing in AVMs at this time. Caution for non-target embolization should be taken, as we know that this can go through and through. Utilization of this liquid embolic, I feel you have more control. It's a cohesive agent as opposed to MBCA or glue, which is an adhesive agent. Clinical questions were raised as a result of the case. Well, can onyx be used as an adjunct to pulmonary AVM embolizations? We have used liquid embolics in other aneurysms whenever there's a scaffold that can actually be built and just utilizing, just filling up the spaces. And this cohesive agent can actually attach to other things to decrease the risk of any non-target embolization itself. Now, some scientific questions and just off the wall things. Well, what's the rate of recanalization after embolization with a liquid embolic? This patient has remained, this pulmonary AVM shut down. And just off the wall too, is there a liquid embolic that can be developed to both be effective with embolization and limit non-target embolization better than or equal to our coils and plugs? Now, I ask this question because we are just pushing the envelope with innovation. We know that we won't use particles for this particular situation, but there's a lot of things that are being developed, maybe some things down the road that we can consider adjunctive use, and maybe as well as primary use for some of these complex AVMs. So thank you very much. That's the end of my presentation, and I can actually one more thing. What are some insights learned from this case? Well, overall, a lot of us who treat AVMs, we want to aim for total occlusion, and we try not to get to the situation where we have recanalization of our pulmonary AVMs, because it is the bane of our existence whenever we're treating this particular disease.
Great. Thanks, Dr. Roshan. That was great. I want to open it up to the group and for discussion on what their thoughts are on this liquid embolic sort of strategy and their sort of thoughts moving forward on recanalization techniques.
You know, I have some thoughts on Onyx. Oh, sorry. I have some thoughts on Onyx. I've used Onyx for, obviously Onyx is approved for the brain without a peripheral indication, as you mentioned. One of the issues that I think is different between the brain and the lungs is the amount of motion that happens over, you know, the countless respiratory cycles. And I've seen in the Onyx that I've used for different chest wall AVMs that don't have to do with HHT, over time I've seen fractures of that Onyx where you get this kind of segmental, it's kind of brittle over time, and you get these intermittent segmental fractures. And I've always been a little concerned that they would distally embolize. But I think we should at least accept that Onyx may be a good option for some of these cases like the one you just presented.
This is Vlad Shenzon. So certainly a novel application of Onyx. We use Onyx quite a bit at Columbia, not for PAVMs. We're not brave enough yet, but some thoughts on using Onyx, I guess, in a way that it does not non-target embolize. We, you know, for something that we want Onyx to move slowly, we use Onyx 34, and we use a balloon of flow occlusion with Onyx. In other words, we use a catheter like a sniper. You can blow it up behind the Onyx, and you can inject Onyx slowly without the blood flow kind of carrying away the Onyx. And I wonder what you guys think about this technique.
Scott Turatola, maybe if I can put my 2 cents in, I'll never forget the day I called Bob White and many years ago and asked him about doing exactly this with a liquid embolic and a recanalized PAVM. And I just can just sort of remember him, you know, screaming at me saying, whatever you do, don't do that, don't do that. And I, you know, I'm going to be the old fashioned guy here and say, I still don't think we need to do that. I think we should work more towards making sure that we get the PAVMs embolized up front. I mean, anybody who's using just coils right now to embolize PAVMs isn't practicing evidence-based medicine. We can get with plugs, we can effectively completely embolize PAVMs and almost never get persistence if we're close to the sac. And you know, quite frankly, I just, it's been a long time since I've treated any PAVM with just coils.
But unfortunately, a lot of people are getting embolized in the community with coils. And, you know, as Dr. Fonen's, I believe it was her 2010 Millick paper, Andrea Millick paper, nicely demonstrated that, you know, that one of the main factors associated with reperfusion is poor coil density, like 1 coil. And I still run into a lot of patients that have 1 or 2 coils in a PAVM. Many of them were treated a long time ago, but I still see them in the modern era, and we're forced to deal with the complications. So would you, Scott, in that case, you've published on stent grafting over feeding arteries. What is your thought on how would you manage if you can't get any more coils in the feeding artery?
Well, if it depends on whether, of course, if the feeding artery is suitable to do that, then that's definitely an option. It works very well, but you know, that's probably the exception rather than the rule. You know, a lot of these folks, when you see them, they've been embolized right back to sort of a major branch point, and there's the vessels tapered and whatever. You know, I think that, you know, those that you're seeing that have had 1 or 2 coils, they're usually very easy to cross, and we can embolize the far side of them and, you know, put a plug on the far side or whatever. And we did a couple of those just last week. This one, I don't know, Paul, whether you tried to cross this or not. You know, as we published, it's only about a 50% success rate in doing that. But I still think that should be plan A. Plan B, Miles, if it's conducive to a stent graft, I would definitely do that. This is not something that I've tried and not something that I'm thinking about is the right thing to do. I'd love to hear Jeff weigh in on this because there's this whole question about whether persistence is even significant.
So, we looked into that a few years ago. And this patient, I think the SAT went from 93 to 94. So I don't think it made much of a difference in the patient's saturation. And the coils that were in there were pretty dense. It's hard to believe that if you looked at that in cross section that any significant size clot could get through. Right, so I think the risk of a large paradoxical embolus resulting in a stroke or something like that is probably pretty low with the pre-existing coils that were there. The issue is, does the risk for bacterial paradoxical embolization go up if you have such a significant size shunt remaining? I don't think we have the answer to that. Was it essential to embolize it? I think is another question to ask. The other way to approach these, there's at least one, and I think 2 case reports of transseptal transvenous embolization in this situation. I personally have never done it. I had one case where I almost did it, and kind of the patient decided against when I spoke to our pediatric cardiologist, and I guess EP docs do that nowadays as well. And I would have gotten them involved to help me to do a transseptal approach. But that's the other potential way you can get to this, if it has a nice vein that you can go into. So the question again I say is, was it essential to embolize this? Because the coils were pretty densely packed in there, even though there was still flow probably through very small channels between them. Right? Was it clinically essential to do it? I guess we're not going to get a lot of weigh-in on that one, huh?
Well, we all struggle with that. I mean, I don't know. I think you hit all the points about the infectious complications being the concern, because that doesn't seem to be as associated with feeding artery size as it does, with embolic stroke.
Yeah, I agree. I think that one of the many things Scott Triotola taught me is that if that echo still shows a grade 3 shunt, you need to be concerned about stuff. Is there reperfusion you're missing somehow? Or are there just a bunch of small AVMs that maybe you can fix with feeding arteries of 1.5 to 2 millimeters? So my goal is to reduce the risk of stroke through an AVM, and I think I agree with Jeff. We've probably done that with that particular AVM right there. It's a steel wool of tangle through there. Clot's not getting through there. And then once we've done that, is there a role for getting the shunt grade down from grade 3 to 2 or 1? It just seems like that has to reduce the risk of brain access if we do that. Although that's not known for sure. It just makes sense. Those are kind of my 2 goals with these kind of patients.
Great. That was a great case, and thanks for presenting that, and some great discussion. So we're going to go on to our 4th case from the University of Pennsylvania. We have Dr. Monica Matsumoto, who's a first-year radiology resident in the integrated interventional radiology residency program there. And she'll be presenting an interesting case of the challenges of managing a pregnant patient with multiple pulmonary AVM.
Monica. All right, thank you very much. Thank you for the introduction. I'm again presenting a case today, and my mentor is Dr. Scott Triotola, who is the chief of IR here. So we had a 33-year-old female who presented with hypoxia. She was actually 37 weeks pregnant, didn't really have any significant past medical history. She presented to an obstetrician for external cephalic version. She was found to have a pulse ox of 92% on room air, which did improve with nasal cannula. And then on further history, she did endorse some daily self-resolving epistaxis and mild exercise intolerance during pregnancy, but she was otherwise asymptomatic. She had no family history of any strokes or abnormal infections. And then on physical exam, she did have telangiectasias on bilateral digits with mild cyanosis, but was otherwise unremarkable. She got an EVG, which demonstrated borderline hypoxemia and respiratory alkalosis. Chest X-ray demonstrated vascular congestion. So she did undergo a CTPE, which did not demonstrate a PE, but did show multiple bilateral pulmonary AVMs. You can see large burden on the left lower lobe, left upper lobe, lingula, as well as on the right side. So she thus met the criteria of HHT, and after a multidisciplinary discussion with obstetrics, pulmonology, anesthesia, and of course IR, she underwent an urgent 2-day stage IR embolization of these AVMs to mainly decrease the risk of paradoxal emboli associated with childbirth and the theoretical risk of PAVM rupture. Moderate sedation was used with midazolam and fentanyl. And on the first day, we embolized 17 separate vessels feeding approximately 12 PAVMs. Took about 90 minutes, 300 cc's of IV contrast were used, and the total radiation dose was about 2,400 milligray. Diagnostic arteriography here was used to evaluate the angioarchitecture of the PAVMs, and all PAVMs were treated with one plug plus or minus a coil depending on the plug type. So I just demonstrate some of the images, example of a large complex AVM, which was embolized with a plug as well as coils, and then some of our proximal feeding vessels were also embolized. Additional coils, some more proximal vessels on the right side as well. A plug and a coil here. So after the first day, after the first embolization procedure, demonstrated complete occlusion of the treated PAVMs with some residual ones remaining, but none with a feeding artery of over 3 millimeters or with a sac diameter of over 6 millimeters. Then on day 2, she underwent a second embolization. 5 separate vessels were embolized, feeding 5 PAVMs. The procedure took 50 minutes, 200 cc's of contrast were used, and radiation dose was about 1,300 milligray. And again, here's some images from that procedure. And on post-embolization arteriography, there were no significant PAVMs remaining. There were some small ones, but none that required treatment. So on follow-up, she tolerated both procedures very well. Her oxygen requirement did decrease. Her ambulatory saturation was around 90%. There was the discussion of whether or not she needed oxygen for the remainder of her pregnancy, but because she had a normally grown fetus on ultrasound, the decision was made by pulmonology and obstetrics that she could be discharged on room air. She did end up undergoing induction of labor 15 days post-procedure with a goal to deliver via spontaneous vaginal delivery, but she did ultimately undergo C-section with spinal anesthesia due to arrested dilation. And note the plan, if she had gone into labor within 2 weeks of these procedures, the plan would have been to do a C-section. And then, of course, if she had been unable to get these embolizations at all, she definitely also would have been recommended to undergo a C-section. She had an uneventful peripartum period, had a healthy baby, and oxygen saturation did improve to 94% on room air after delivery, epistaxis resolved, and exercise intolerance improved on follow-up. She did endorse some mild left-sided pleurisy for 1 week, but otherwise felt well. She was counseled on PAVM precautions, has given consent for genetics, but that workup is not yet complete, and 6-month follow-up CT and contrast echo are pending. And I did also want to note that she did undergo an MRI of brain, spine, abdomen, and pelvis before the embolizations. And they did show chronic infarcts, small infarcts in the left cerebellum. But there were no other visceral PAVMs, no spinal AVMs. So that's one of the reasons why they felt confident doing spinal anesthesia, although there is some evidence that that may not even be necessary as far as pre-procedure workup. So as far as things to take away from this case, definitely need multidisciplinary management for patients that are diagnosed in the peripartum period. including workup, as I mentioned, timing of embolization and how the baby is going to be delivered, and then also the role and safety of urgent PAVM embolization in the 3rd trimester, with the goal of treating the maximum number of PAVMs until reaching contrast or radiation maximum, assuming the patient is tolerating the procedure as well. Clinical questions: what's the safe timeline for vaginal delivery after PAVM embolization versus requirement for C-section? Would this change if AVMs have been diagnosed in the fetus on imaging? And if workup had identified other AVMs, such as in the spine or brain, how would those best be managed? And what is the order of priority for treating them? There are additional scientific questions, such as are certain HHT genotypes more susceptible to growth or rupture during pregnancy? I don't think there's really any data out there on that. And then can cellular mechanisms that occur during pregnancy that alter the architecture of AVMs be targeted with therapy in the future? Insights, again, prioritizing the treatment of largest PAVMs with plugs and plus or minus coils to minimize peripartum risks. And then embolizing these PAVMs in the 3rd trimester of pregnancy as soon as possible to minimize peripartum complications. And I think for patients in general, if they're diagnosed during pregnancy, they're recommended to undergo embolization during the 2nd or 3rd trimester if they can't get it done before they become pregnant. And then, of course, coordination of care among all the different specialties. Definitely like to acknowledge Dr. Triatola, as well as the other IRs who help with the embolization procedures, Dr. Susan Shmimi-Nuri and Dr. Neil Harrison. Thank you very much. And here's the questions recap.
Great, Monica. That was great, and you really did her a great service through your diagnostics and therapeutics there. Perhaps someone can try to tackle that first question about the safe timeline for vaginal delivery after AVM embolization. What typically would you? How long would you wait, and any recommendations for vaginal versus C-section?
That's first of all, thanks, Monica, for a great presentation. Really interesting case, and I agree with Keith that this is a good thing you did, a great thing you did. In terms of that first question, I'm not sure why we need to wait, to be honest with you. Maybe there's something I'm not thinking of, but I think I would feel quite comfortable proceeding to vaginal embolization, vaginal delivery, pardon me, at any point post embolization, given that it's not like we need to, I guess at any point, maybe 24 hours or more after the embolization, because my only thing would maybe wanting to be just sure that they, that they haven't developed any complications or there's, no other intercurrent issues. But otherwise, I would be comfortable 24 hours after or the next day, proceeding with vaginal delivery. And there are very few situations where I would recommend a C-section. So that would be my best answer. Do you have a specific concern about proceeding early that I'm not thinking of? Because my sense is that the success of embolization occurs, is kind of complete within 24 hours, and that we may assess it later, and the shrink, the involution happens later, but that the success is immediate and sort of completing within the hours after embolization. So I would think we'd have reduced the risk.
Yeah, Marie, it may make sense for me to answer that question. This is Scott. We have this sort of no heavy lifting for a couple of weeks after embolization, with the concern that when you exert yourself, that it cause the vessels to expand and might get dislodgement of the embolic device. And, is that evidence-based? Absolutely not. But it's something that we have out there for pretty much all of especially our venous embolizations, where you do have big changes in the diameter of vessels and that sort of thing. And I think that was the concern here. I think one of the things that we were really happy with was that she was able to have a go at SVD, because it was her first child. She really wanted that. And I think she was, in talking with her afterwards, she was really happy. Ultimately, it didn't go that way, but and you can see it was day 15. It's not right. Like, is that right or not? I don't know. That's why we're asking the question.
Yeah, we tell patients no heavy lifting for 48 hours after embolization, but honestly, I've always told them that for the femoral access. I've never thought that, I've never had any concern about the embolization per se, but it's an interesting idea. Has anyone ever documented any issue with effort or, like I said, post embolization? Okay.
Well, one thing
interesting
is,
question. I just hadn't thought of it. Yeah.
Yeah, I mean, the one thing I think is that if you use some of these delicate devices like some of the plugs, so the MVP, the microvascular plug, that thing migrates in systemic arteries. And I had one migrate in a pulmonary artery. About 3 months, there was a gentleman who was doing demolition at Candlestick Park in San Francisco when they were tearing it down, and he was hurling large chunks of concrete. And about 3 months after his PAVM embolization, he got a CT for unclear reasons, and it showed that it had gone into the pulmonary vein and was lodged sideways. And that was my experience with that plug, and I vowed to never live by, put it when it's basically, I want to oversize it more than an Amplatzer after I learned that lesson.
Interesting. Okay.
And of course, we don't know when it embolized, right?
What's that?
Could have been 24, could have been 5 minutes afterwards.
Yeah,
we don't really know when
knows?
that thing embolized, right?
No.
But definitely we should recommend
no
hurling large concrete blocks.
Well, I had another patient who was a trumpet, like a very good trumpet player, and he was really doing the Valsalva maneuver, and I was worried about that too. So I had him doing no trumpet for 4 weeks.
Jim, have you, what would your advice be about safe timeline for vaginal delivery after embolization?
Yeah, same thing, but it's based on just guess. I mean, it seems to me that the benefit from a hemodynamic and a oxygen saturation and potentially rupture standpoint would be almost immediate as soon as the vessel's occluded, but I don't know that. That's a guess. It's a great question.
And I can think of only a couple of cases where we, delivery soon after embolization, just that we haven't often had that sequence. Sometimes like this patient, we've embolized and we've said, okay, the patient's safe now and we can wait for them to deliver spontaneously. And they go home and come back, and other patients, we couldn't we delivered and then embolized in certain situations, but most cases we would deliver and stabilize and then either keep them in hospital till they deliver, or if we're really happy that they're low risk, then we would send them out.
It may be helpful to think about analogous systems. If you think about the AV fistulas, with the declots, that we try to, declot these sooner rather than later, within 72 hours, because we know that there is a fibrin formation within the clot. So, if you extrapolate this to the pulmonary AVMs, perhaps after 3 days, there is enough fibrin to stabilize the clots, to stabilize the coils, that it would be safe to do any kind of extraneous activity like throwing, concrete chunks or delivering.
I would, Monica, I'd be happy to take a stab at the second question too. I think if you had found, if this were my patient and we found AVMs in the brain or spine during pregnancy, we would not be treating them during pregnancy, and that we would be consider them on a case-by-case basis for treatment postpartum, like a few months postpartum. That's been our standard clinical approach.
But by the way, Marie, that pan scanning, which is in violation of the guidelines, was done before we got hold of the patient.
I was just going to mention that.
It's always like that, isn't it? It's always like that at the centers. We're trying to be so parsimonious and careful with the imaging, and elsewhere they just do the whole thing.
Oh, it happened in our own center, though. I mean, it's embarrassing.
Right.
Well, thanks, Monica. That was wonderful. And we're now off to our last case of the day. We have from Washington University, we have Scott Bugenhagen. He's a cardiothoracic radiology fellow who's presenting a pediatric case of suspected HHT with ultimate misdiagnosis of vascular lesions.
Thanks, Dr. Brenner, for the intro. Yeah, this is an interesting and somewhat confusing case we came across at our HHT Center. Let me change to screen share mode. So this was an 11-year-old boy who presented for evaluation and management of hereditary hemorrhagic telangiectasia, diagnosed at age 5 when he was evaluated for nosebleeds, iron deficiency, anemia, skin lesions, and pneumonia. At the outside institution, he was reportedly found to have AVMs in the right lung, which they did coil. Subsequently, he developed recurrent GI bleeding and hematemesis before coming to our center. And he was told at the outside place that he had the AVMs in his lungs were past normal parameters and that they couldn't coil them. So he was referred to our HHT Center for further evaluation, which included a chest CT and pulmonary angiogram. So here's his chest CT. So this is the topogram, and we can see the coils, multiple coils, 4 coils in the right lung, which we can see here in the transaxial lung window images. And we'll take a closer look at those in just a minute. Here are coronal MIP images of the lungs, and what we see, the pulmonary artery vasculature is pretty normal appearing, but the venous vasculature, there's multiple tangles of veno-venous collaterals that we see in the right lung. For example, here, here, and then also a similar tangle, smaller tangle in the left lung here. And we also noticed that, so these tangles, the collaterals they connect from the branches of the right superior pulmonary vein and connect to the branches of the right inferior pulmonary vein. And we can see that the right inferior pulmonary vein is markedly dilated and tortuous. You can see it here. And here's emptying into the left atrium. And we also, on this image, we get a good look at the right superior pulmonary vein as it kind of enters into the left atrium. And we can see this apparent web here and this narrowing, suggesting obstruction of the right superior pulmonary vein at the ostium, kind of leading to the development of all these veno-venous collaterals. And this is just another look. Here's branches, collaterals coming from branches of the right superior pulmonary vein to the right inferior pulmonary vein. Similarly here, here we can see kind of collateral coursing through, connecting there inferiorly. And then also that tangle that I showed you on the left, we can see nicely here, this collateral coming across and connecting to the inferior pulmonary vein on the left. And now taking a closer look at those coils in the right lung. So here's the right main pulmonary artery and then multiple branches in the right lower lobe. All pretty normal appearing pulmonary arteries. And then here we can see that coil kind of at this normal appearing right lower lobe pulmonary artery branch, and then another coil at another branch here in the right lower lobe. And then similar kind of normal appearing pulmonary arteries that were coiled in the right upper lobe. And another unusual finding with this case was there was this hyperlucency in the right medial and posterior segments of the right lower lobe, which is a pretty atypical, unusual thing for HHT that we saw in this case. So here's images from the pulmonary angiogram. So here, so we're injecting the right pulmonary artery, and again, pretty normal appearing right pulmonary artery vasculature. And then no evidence of AVMs that we can see in the angiogram. And then again, we're seeing those kind of those tangles of veno-venous collaterals and tortuous dilated appearance of the right inferior pulmonary vein. And then again, we're seeing kind of that narrowing of the right superior pulmonary vein here and kind of suggestion of obstruction of the right superior pulmonary vein on the right. Similar sort of picture on the left, normal appearing pulmonary arteries on the left, no AVMs, and then those tangles, which we don't really see that well in these images, but which I showed you on the CT. And then because the patient was also having GI bleeding, we also did superior mesenteric artery and inferior mesenteric artery angiograms. So here they're injecting the superior mesenteric artery, and again, pretty normal appearing branching pattern of the arteries here, but basically completely abnormal venous supply of the superior mesenteric system, multiple enlarged and tortuous varices. The superior mesenteric vein was found to be occluded, and there's reconstitution to the portal vein through this collateral vessel. And then on the inferior mesenteric angiogram, similar, very abnormal venous system. Basically, the entire inferior mesenteric venous supply is drained through this small collateral along the mesentery, which drains into the splenic vein. So things that we learned from this case, it kind of showed the importance in these complex cases of taking an unbiased and sort of just an open-minded approach to working up these complex cases and thoroughly and critically reviewing the prior history, including clinical findings and imaging findings. And in this case, imaging did play a key role in excluding HHT and identifying the true cause of this patient's symptoms, which were these multiple pulmonary and mesenteric venous obstructions leading to multiple varices. And kind of this imaging helped direct further management. Other clues that we found on workup, non-imaging related, included absence of family history, negative genetic testing. They did some superficial skin biopsies as well as biopsies of the liver and bowel, which were all normal. Some unanswered clinical questions that we had during this case. So we still don't know if the pulmonary and mesenteric venous obstructions are due to kind of congenital narrowing or absence versus thrombosis. In our workup, we favored thrombosis. The patient did have multiple prenatal and neonatal complications, including his mother had influenza 1 week prior to delivery, and this was associated with decreased fetal movement, oligohydramnios, and neonatal SVT, which was treated with beta blockers until 6 months of life. So we're thinking that this may have contributed to a low flow state, which could have led to multiple thrombosis. What we don't know if there's an underlying hypercoagulable state that could have led to thrombosis. We did recommend that, although we don't have follow-up to see if that was the case. Another interesting point was that his mother had a history of miscarriage, so that also suggested that antiphospholipid antibodies may have contributed. And one of the clinical kind of management question that came up was whether sclerotherapy of selected varices would have been helpful or would have just led to further reduction of blood flow. Ultimately, we recommended a conservative management. Some scientific questions that were raised. Is it possible that intrauterine neonatal low flow state alone in the absence of a predisposing hypercoagulable condition could lead to development of this pattern of thrombosis? And if so, over what time frame would kind of these complications of this condition be reversible if we were to recognize it early and start treatment? And if these instead represented congenital venous anomalies rather than thrombosis, are there other possible genetic associations that could be contributing to these findings? And then some overall insights, how we would handle future similar cases in the future. Like I said before, this kind of highlights the importance of kind of critically reviewing prior history and clinical and imaging findings and taking an unbiased and integrative approach in evaluation of complex conditions such as HHT. So this patient had documented diagnosis of HHT for which he had got treatment with coils, but kind of after carefully reviewing everything, we pointed to an alternative diagnosis, which changed his course of management. And then in kind of when working up HHT, it kind of shows that veno-occlusive syndromes resulting in veno-venous collaterals and varices can mimic a wide variety of clinical findings associated with HHT. So things to pay attention to if you ever come across similar unusual findings in your clinical practices. So I'll just open up the floor to discussion.
So a great job, Scott. That was an interesting case, and I'm glad you finally sort of came to the root of the problem there, or at least excluded HHT as a probable diagnosis. Just was wondering from the group, does this clinical presentation ring any bells as far as an HHT-related genetic condition? But when I was hearing the case, I was thinking of the capillary malformation AVM syndrome that may be RAS-1 associated. I've had a few patients that have presented with more venous and lymphatic anomalies.
Keith, I can't speak to that. This is Scott Trotola. I can't speak to that, but I'll tell you that I get 3 or 4 of these a year that look like this from various reasons, everything from prior cardiac ablation to just congenitally malformed pulmonary veins. You know, they're just PAVM fools. And once you get to be a center, people just start to send you stuff. I mean, I had somebody sent to me this week whose CT showed mucus plugging, which was read as PAVMs. I kid you not, real thing. So I think it's a beautiful example, Scott. Really nice presentation, and it's just the key thing is to recognize it and not go down the garden path of treating something that doesn't need to be treated.
I'm curious to know whether you were able to see the arteriogram that was done at the outside institution. What was it that they were embolizing? Were they mistaking the veins as arteries? Were they not sort of paying attention to what was arterial and what was venous? What was it that they embolized?
Yeah, that's a good question. We had a similar question too. Unfortunately, we weren't able to get that outside imaging. This is an older case from 2013, but just kind of reviewing the notes and stuff, it looked like that they embolized these normal appearing pulmonary arteries, thinking that they may have been feeder vessels, although we don't have the actual imaging to kind of confirm that.
And just along the lines of what Scott said, I've seen a number of those cases too. And one thing I've learned to do over the years is when people send me things that don't really look like HHT, no other features for HHT, and they're saying, hey, this looks like a pulmonary AVM. I always like to look at the lesion and make sure that there's actually both an artery and a vein going into it. Because a lot of times you just look, not a lot of times, but sometimes you just look and there's just 2 veins. Or there's 2 arteries and it's just a tumor that's got 2 vessels going into it, and the bubble echo is almost always negative in those cases. So just a complete evaluation with bubble echo and a really good, thorough look at the CT can save you angiograms and things like that.
And that's the great point, Jim. The grade 0 echo is the real key, you know. Yeah. When in doubt, you know, the patient, you know, has already been scheduled at my office or whatever. I see him and say, look, let's just get an echo. We'll solve this once and for all. And, you know, unless it's a false positive, you're in good shape.
Scott, were there other aspects of the case that besides the suspected pulmonary AVM, the patient did have a history of epistaxis? Is that correct?
That is correct. Yeah. And he had, epistaxis, some skin lesions as well, from what I recall. So there's a few things that were kind of maybe serving as a red herring leading to HHT. He did have those liver and bowel biopsies, and then the genetic testing for HHT as well.
Great. Any other comments on this case? All right. Well, if not, I think we're just about out of time anyhow. And so I just want to say thank you for all the presenters and all the participants. These sorts of things are really helpful, I think, for everybody, especially for someone at my phase in my career, to sort of see these interesting cases and really to get the experts in the field to really to get their assessments of what's going on. It just was really helpful for me, and I hope everyone else agrees. I'm just going to turn it over, I think, to the HHT folks here, HHT Cure, and for the next announcement.
Hi, again, I want to thank everybody. This has been great discussions. And I know time was limited, and so we would like to continue the discussion on the HHT physician listserv. If you would like to join the listserv, you can email curehht+subscribe@groups.io. And if you're already subscribed, you can view the discussions at groups.io/b/curehht. And I will be sending a follow-up email with the recording of this meeting, as well as links to this physician listserv, as well as a quick survey to get your feedback on today's meeting. And finally, the next meeting will take place in October, and we'll be focusing on liver AVMs. So keep an eye out for the email invitation to register for that meeting as well. And thank you all again. Big shout out to Miles Conrad, and as well as our hosts, Keith Brenner and Vladimir Shenzan. Couldn't have done it without you guys. And yeah, thank you very much. Yeah.
Thank you. Take care.
Take care, everyone.